I'll be attempting to give you what I refer to as the Gatecrasher's introduction to health inequalities. I call it Gatecrasher because in the normal run of things, being a language person, I have no business hanging around with you eggheads. But for some strange reason, we have come to think of matters relating to public health as involving all of us, irrespective of our disciplinary backgrounds. So that is why I believe I have the courage to be hanging around you guys here. So I basically will be giving you my sense, my understanding of health inequalities, and then scoping what I imagine is the role of the language scholar in addressing health inequalities. So that's basically the thrust of the presentation I'll be making. Okay, let's start with a pre-talk discussion. Let's check what our convictions are, what we believe as far as the subject is concerned. A very popular writer, George Orwell, says all animals are equal, but unfortunately some are more equal than others. Unfortunately, even though we would have hoped that before God and man we're all equal, but somehow, unfortunately, some are more equal than others. Now, let's try applying that to the context of health. We have a couple of questions here. Do we have equal opportunities for good health? In other words, do we all have equal chances of being healthy? Are we equal before disease and death? So imagine disease and death standing here and looking at you all. Are we all equal before disease and death? Are health risks and opportunities to remain in good health equal, or are they unequal for all individuals? Now let's further contextualize individuals here. Individuals of all sexes, individuals of all ages, individuals living in different parts of the world, individuals of different ethnicities, races, and nationalities. Are we all equal before disease and death? I wonder what your answer would be, but mine would be, unfortunately, we are not. And that therefore introduces us to our subject matter of inequalities in health. Let's look at a couple of data just to further contextualize this answer I've given, that regrettably, even though we would have wished that before death and disease were all equal, there was no discrimination along lines of gender, along lines of age, along lines of geography. Unfortunately, there is discrimination there. Okay, if we look at this, look at life expectancy, look at a couple of social classes in England and Wales. What we see, unfortunately we don't have a pointer here, but what we see is that, let me see if I can get a pointer. Well, it doesn't matter, it's not coming up. So what we see is that there's something of a gradient, all right? As you move from the social class 1, okay, which is the professional group, down to class 5, which is unskilled manual people, there is almost a step-by-step drop in life expectancy. So what's the picture this communicates? If you're a professional, your life expectancy is different from your life expectancy if you are an unskilled manual individual. Okay? Unfortunately, that is the case. Now, the same data set, but now viewed from a different perspective, gives us even more details into the disparities between social classes. And it also gives us a time perspective. If you look at, let's say, the age group 25 to 34, and the year 1931, we see, here we're talking about mortality, annual deaths by 100,000. Now we see the number of deaths in 1931, and then we see that that number has dropped significantly by 1991. So there is almost, if you like, a sevenfold drop here, all right? But if you now look at class 5, in 1931, we have about 374, and by 1991, we have just 187. There is a drop, but it's just about a twofold drop here, whereas here we had a sevenfold drop. So what is the picture? The picture we see is that generally, health indicators are improving, okay? However, in some cases, within classes, the gaps are being exacerbated, are being aggravated, okay? And you see this very clearly in this series of charts. So look at the gap in 1931 for this particular age group, okay? Between the best performing and the worst performing classes. But by the time you come to 1991, you see that the gap is a lot more. So yes, things may be improving generally, all right? There's a drop, but the rate of decline is faster in some groups than in other groups. Let's move on to a beautiful city called Barcelona and see what's happening there with respect to infant mortality rates. Okay, so there's Barcelona, the rest of Barcelona, and then there's a sort of semi-rural community. Now, what do we see? In Ciutat Vella, we see that consistently, over this time periods, the infant mortality rates are higher, okay, in Ciutat Vella than in the rest of Barcelona. So even infants are not equal before disease and death. Now let's look at continents. If you were to look at a map of the world, just based on population, you would have the first picture there. All right, so some countries almost do not exist. Others are very, very important, particularly in this part of the world where we are in terms of population. But when you now look at the world from the standpoint of HIV/AIDS related deaths, the picture of the world changes. Some countries disappear and some others become extremely bloated, very, very important. Okay, so there are disparities as far as HIV/AIDS related deaths are concerned. All right. Okay, you look at, let's say, health utilization, okay, as another indicator. Look at health utilization, let's say in South Africa. What do you see? In terms of gender, you see more females accessing health services than males. You see more whites accessing health services than, say, colored and blacks. In terms of socioeconomic status, you see more people in higher socioeconomic classes accessing health than people in lower socioeconomic classes. Again, disparities. From whatever lenses you look at the picture, you see the same story of differences. Even if you look at how satisfied, people's self-assessment of how satisfied they are when they encounter health service providers, you equally see disparities, differences everywhere. About 31% of blacks are likely to say that the services they get are excellent. 38% of colored or Indians would say it's excellent, but 61 would say excellent. Again, disparities, even in perception of the quality of care. So everywhere you look at, you see disparities. Germany, this is somewhat older data, looking at mortality and income in male employees. Again, the same type of gradient we saw in England and Wales initially is what is replicated here. So if you were earning big, all right, you belong to a much lower class in terms of mortality rates. But if your earnings were much lower, then you belonged to a class with a much higher mortality rate. Okay, so we can go on multiplying this data, but I think with these data sets, a number of pictures have emerged on which we can now do some reflection. And here I would invite you to participate. So having looked at these data sets, what health indicators were used? What health indicators were used, and to what variables were these indicators linked? In the South African example, race. Okay? In the South African example, race. All right? And you saw how each of these variables sort of affected performance on these indicators. And the example from England and Wales, again, confirms what we said earlier on, that although there's a general improvement in the performance on these health indicators overall, however, when you look at the interclass performances, as it were, you see that in some cases the gaps are getting wider, not closing down. So the question for us is, should we, as demographers, health policy folks, other social scientists, should we be concerned about these differences? Okay, should we be bothered? Or should we just adopt the attitude, well, inequality has always been there and therefore we live with it? I think we should be concerned. Now, let's move on quickly now to dimensions. Let's first wrap this up and sort of attempt to define health inequalities and then look at dimensions of health inequality. Okay, somebody has defined health inequality as a universal phenomenon. In other words, everything you find, something you find everywhere, that deals with variation in health indicators. Variation in health indicators. So whether it is morbidity or it is mortality, we're talking about variation in health indicators associated with what? With socioeconomic status. So variation in health indicators associated with socioeconomic status. I might note, just a terminological point, because I have a bias for technology, that in much of the American literature, you will not find the emotionally charged term health inequalities. What you will find is health disparities. Again, that's a very ideological thing. They don't want to feel bad by speaking of inequalities, so they speak of the more neutral disparities, okay, to make their governments feel better. But we're talking about inequalities. That's what they are. Let's call it by the name, inequalities, to make us feel bad and to galvanize action. But when you say disparities, all right, diversity is, or has it put, is the spice of life. So it's nice to be different. But we're not talking of just that kind of difference. We're talking of differences we can do something about in particular. Okay, there's the term inequalities, but there's also the term inequity that is often used in the same context of our discussion. So it's important to disentangle both. So whereas health inequality has to do with those variations that we just seen. Health inequity or inequity has to do with those variations that are what? That are considered unfair, that do not have a raison d'etre. Why? Because communities and governments can, if they wish to, do something about them. So those unfair instances of variation would be what would be referred to as inequities. So inequities, health inequities, will be a subset of health inequalities. Okay, let's try another exercise. We are going to look at a number of determinants and try and see whether, as concerned as Professor Naya may be, with respect to the subject of health inequalities, whether it is all kinds of variation that he's interested in. Let's see how committed he is to changing the world. Is it all kinds of variation that he's interested in, or there's a subset that he's interested in? Okay, let's imagine premature death of an individual due to, let's say, natural biological causes. Would this be inequity or inequality? Would this be considered unfair? If an individual died of a natural cause, or something that had to do with biological differences, some genetic type thing, would we consider this as of interest to scholars of social inequalities in health? No. I can see the gentleman there shaking his head, so 2 points for you. Who wants to be a millionaire? Okay, so you've got your first million. All right, how about freely chosen health damaging behavior? Again, I know we can have an argument about this, whether a behavior is freely chosen, but you'll see my next point. But let's say for some reason you wake up this morning and you ask for all of the packets of cigarettes in Delhi, all right? And you go to Kingfisher and say, look, over the next 10 hours, I want you to supply my room in Aravali with as much beer as you can. Today is my day. Now, if I started on that path and something happened to me, would this be of interest to Professor Naya, who is interested in health inequalities? What do you think? No, he's not that considerate. He says, Bassey, that's your problem. Okay, go. So that will not be of interest. However, if the damaging lifestyle were imposed on me by a number of socioeconomic factors, would that be of interest to Professor Naya? Yes, it would be of interest, so 2 points there. How about exposure to health hazards as a result of where you live? I mean, look at where we are, so very comfortable, we are not exposed. But if we were in some other locale, some other localities, where as a result of work, we were exposed to asbestos and other things that impact our health, would this be of interest to a scholar of health inequality? Yes. You have 5 million already. Okay, restricted access to healthcare, would that be of interest? Right, it would be of interest. Now, health, your health state makes you go down the social ladder. Okay, would that be of interest? Absolutely, it would be of interest. Okay, so I see Oliver is back, so let me move swiftly now. There are a couple of dimensions in the work done in the area of health inequalities. Some are keen to describe the magnitude of the problem, the nature of the problem. Others are keen to offer explanations. All right? Why do we observe what we observe? And yet others are more interested in intervening. What can we do to reduce what we have observed? So, three major pillars of the research and of the work that is done in this field. I've tried to elaborate on each one, but I'll skip through. So basically, in description, what is the nature and extent of inequalities in a given environment, either diachronically across time or synchronically at a given time period. And this is a typically quantitative undertaking that uses different kinds of data sets. Explanation, a number of explanations have been offered in the literature, from material to psychosocial life course explanations. For instance, the material explanation simply says that low income, where you work, exposure to health risk and all of that affect the variation that we see. The life course would say that it is not something that happens right now that explains the variation. Rather, it is the history of accumulated disadvantages over the course of an individual's life. You know, you have the cultural, behavioral explanations, who you hang out with and all of that, the psychosocial, the experience of stress, just with stressors there. Okay, let me just begin to round up now. Let's look at reduction. There are several views with respect to reducing health inequalities. Some talk of reducing the gradient, targeting the health of lower social classes and so on and so forth. But I've chosen to focus on Mackenbach's views on how to intervene in order to reduce health inequalities. He identifies, I believe, 4 points. The first is that to reduce health inequalities, to do something about health inequalities, you've got to target power. Okay, you've got to target power. You've got to reduce the inequalities, the brazen inequalities that exist in the way powerful groups enact their power. All right, we'll explain this in a minute. You also have to intervene to reduce the effect of health on socioeconomic position. So, when you're in ill health, how does that affect your socioeconomic status? Does it lead to a deterioration? Or alternatively, what are the financial consequences of being in ill health? Catastrophic health expenditure, okay? All right? So you sick and all of the household income goes, all right? Or reducing the, let's say, effect of these determinants, we saw material, psychosocial and so on people in lower socioeconomic groups, and then reducing the health effects of being in a lower socioeconomic position through health care. Now, what I've basically done to enable Naya justify why he has invited a linguist here, I have basically asked myself the question, how can a linguist be relevant to the attainment of each of the 4 reduction targets spelled out here by Mackenbach and colleagues? For my language colleagues, it's also a statement of what I would like to see as our research agenda going forward, but also a way for me to reflect on some previous work. Okay, with respect to inequalities, reducing inequalities in power, the question we might ask as linguists would be, can language analysis make available for inspection the under the table subtle strategies which dominant groups use? Can language analysis help us unlock the language of those in power? And here I'm quoting Ruth Wodak. The language of those in power who are responsible for the existence of inequalities and who also have the means and opportunity to improve conditions. In order to contextualize this, how language analysis can be useful here, we might ask the question, how do socioeconomically powerful groups enact their power in a variety of settings? It could be in the frame, in the dominant perspective which they bring to bear on health discourses or in health messaging. And I have an example here. These are HIV messaging samples. And if you look consistently at the way the messages are worded, you can see that it is the perspective of seronegatives that is highlighted. So when you say bad news, HIV/AIDS is real and deadly, good news, HIV/AIDS is preventable, we ask, why don't you put good news first and then the bad news later? Or HIV/AIDS is real, don't ruin your life. What's the effect on somebody living with the virus compared to somebody not living with the virus? And then when these messaging samples speak of casual sex, risky behaviors, unfaithfulness in marriage, what is the effect of those messaging samples on people living with the virus and people not living with the virus? The question is, if you brought on board people living with the virus, would the language used have been more sensitive? Would it have been more considerate? In other words, would they have felt less vilified by the messaging than is currently the case? So these are very subtle ways in which we can enact our power, in messaging. But also, during healthcare consultations, whose voice do we hear the most? Is it the voice of medicine, as Mishla says, or the voice of the care recipients? Okay? Typically, in many consultations, some 7 seconds into the consultation, the caregiver takes over. All right? And that is the dominant voice. Or in the power to name, classify, you go to hospital with an illness and you come back with a disease. A name has been put to it, and that name can destroy your life, as it were. So, as linguists, I believe that we can provide evidence of inconsiderate use of power. Okay, inconsiderate use of power through the language choices that are made that reflect certain viewpoints and silence some other viewpoints. Reducing the effect of health on socioeconomic position or the economic effects of ill health. Again, we start off by the question, how might health affect socioeconomic position or family or individual finances? Well, health could affect socioeconomic position through the loss of opportunities, the prejudice that is associated with how we represent certain diseases. Again, you have a number of people, these are newspaper cutouts, who have lost opportunities, either in terms of accommodation or in terms of employment, and so on and so forth, just because they were HIV positive. So the construction of HIV has engendered prejudice. And this prejudice, discrimination that has been engendered, has now been responsible for the loss of opportunities. So, or if you look at health expenses, in an age of consumerism where governments, healthcare providers want you to consume, it's good for the economy, it's good for the bottom line, we are seeing increasingly cases where we are being manipulated into spending out of pocket, at times catastrophically, in order to assess healthcare, at times with questionable benefits. And I'll be illustrating this, my colleague and I will be illustrating this in our talk on Friday. So again, we believe that language research can describe how, at least suggest how prejudice might be fed from the kinds of ways in which we talk about diseases. Now, reducing the effects of determinants in low socioeconomic groups. Again, I basically asked the question to contextualize this. How can, say, the material determinant have less adverse effects than it would ordinarily have in people in low socioeconomic positions. Okay, what kinds of effects do we typically have before we begin to look at the scope for language research? I believe that people who are in low socioeconomic groups will probably have worsened health states due to possibly higher levels of non-utilization of available health services. We saw this in the South African example. Non-adherence, or generally to what is being increasingly referred to as health illiteracy. The converse of it is health literacy. So, one definition of health literacy is that it refers to the skills, the capacities and knowledge required to access, understand, and interact, with the healthcare system. So again, I think there's an opportunity here for language scholarship, an opportunity to investigate the very many different ways in which language interfaces with the attainment of higher levels of health literacy, even when you are poor. All right? Even when you are poor. Okay? All right, I think this is my last slide. How can language or language research enable healthcare to reduce the health effects of being in a lower socioeconomic position? Okay, again the question, what are the health effects when persons are in a low socioeconomic position and healthcare is non-responsive, is inattentive to their low socioeconomic position? Again, worsened health status due to a number of factors, delay in onsets of care, delay in accessing care. Care would often be eventually assessed when the situation has become very bad. Then reliance on perhaps psychologically more accessible healthcare providers who may be incompetent. Then adverse outcomes as a result of misdiagnosis or errors in treatment. The stressors associated with not being listened to when you go to the care provider. Again, in our increasingly multicultural environment with migration, the patient base in many communities is changing in ways we have never experienced. A couple of people now speak not of diversity, but actually of super diversity. In this environment, language access becomes key to health services. All right, so to round up where I started, the point of just trying to make is that yes, although all animals are equal, some are unfortunately more equal than others, and I hope that this presentation has shown that this is very true of the health context. Thank you very much.